Okay. Good morning. Today I'm going to present on trigger finger. So before explaining on what is trigger finger, I explain about the finger actually lah. So this is the distal and middle and the proximal phalanx. So we have tendon sheet and also bone here. Okay, and pulley. So what is the relation? Why I'm talking about pulley now? So this pulley is the one attaching this tendon sheet, tendon and to the bone. So the one involved with trigger finger is usually this A1. So A1 is the one usually will be involved lah. So what will happen is that the definition wise lah, I go to the definition wise. So it is inhibition of a smooth tendon gliding to a mechanical impingement at the level of A1 pulley that causes the progressive pain, clicking and catching and locking of the digit. So that is the definition wise lah. So epidemiology wise, we see the incidence 2 to 3% in general population and 10% in diabetic population lah. Demographic wise, more common in diabetics and also females elder more than 50 years old lah. Anatomically, we can see usually affecting the ring and the long fingers, and most probably the risk factors is diabetes lah. So I'll talk about the etiology part. So the etiology part, so what will happen is that there's a fibrocartilaginous metaplasia of the tendon and the pulley. So increase the size and the change of the cells around the tendon and A1 pulley lah, and proliferation of chondrocyte with increased type 3 collagen, which is collagen is one of the substance of tendon lah, so it will increase. And if let's say, why I say the risk factor of DM, right? So if chronic hyperglycemia will creates the collagen crosslinks lah, which impairs the collagen degradation. So other factors would contribute is the pathologic nodule of the flexor digitorum profundus tendon. So usually trigger finger that two involved tendon is flexor digitorum profundus and flexor digitorum superficialis lah. So this will cause the stenosing of the tenosynovitis at the A1 pulley. So other associated conditions, ortho-wise, rheumatoid arthritis, calcific tendinitis, septic tenosynovitis, carpal tunnel syndrome, congenital trigger thumb. Medically, we can see diabetes, amyloidosis, hypothyroidism, sarcoidosis, gout, and pseudogout. So the classification wise, we have a green classification here. So grade 1 is palm pain and tenderness at A1 pulley. Grade 2 is catching of digit. Grade 3 is locking of digit, passively correctable lah. But the grade 4 is fixed and locked digit. Presentation wise, usually symptoms will come with progressive pain usually at A1 pulley, clicking, catching, and also usually the fingers will be locked in a flex position with at the PIP joint, and then they can have a referred pain to the dorsal, MCP and PIP region. Physical examination, from the palpation, we can have a tenderness at the level A1 pulley and palpable nodule at the flexor tendon. Range of motion triggering with the digit flexion and extension, flex flexion at the PIP joint. There's no the provocative test, usually flexion and extension of digit, which can produce the symptoms lah. Imaging wise, it's not required for this trigger finger. Differential diagnosis, I can give here 3. So which is the first one is elliptical plus finger, which we can differentiate by paradoxical extension while trying to flex the digit. The second one is joint contracture, which we can differentiate by the history of trauma and inability to passively extend the digit. And the third one, pyogenic flexor tenosynovitis, which we can differentiate by the signs of infection, including the possibility increase in CRP, FBC, inflammatory markers and positive canaval signs. Treatment wise, for non-operative, we can do the first one, splinting, activity modifications, NSAIDs, and the last one is corticosteroid injections lah. Operative wise, there's percutaneous release of the A1 pulley, open surgical debridement and release of the A1 pulley, and release of A1 pulley and one slip of FDS. So the complications, there are few here. Around the sheet, the involved with the digital nerve and digital artery. So you can have radial digital nerve injury, bowstringing, wound dehiscence, scar tenderness, stiffness, and tendon scoring. Prognosis wise, right, the survival with the treatment usually relief with injection usually can achieve like more than 90% of non-diabetics. If surgery, if more than 90% of any patients. That's all.